run the Osteoporosis Clinic, so I'm very interested in bone health for the population as a whole. But one of the things we'll talk about today is that cancer treatment in particular can present some risks for bone health, and we'll go through some of those effects. We will talk about how we can optimize your bone health through lifestyle approaches, including diet and exercise. And finally, we'll talk a bit about the medications that can be used to improve bone strength. All right. As I mentioned, this is a topic that I spend a lot of time thinking about, despite the fact that I am not actually an oncologist myself. I am an endocrinologist, which is somebody that focuses on hormonal diseases, including osteoporosis. But one of my areas of clinical interest as a physician is how to optimize bone health for patients during all sorts of cancers. I have a large patient population of women who've had breast cancer. I'm also a researcher, a scientist. I run a basic laboratory at Stanford. And one of the topics that we have been very interested in, and that I hope to have a few minutes to tell you something about later today, is some work we've been doing in the lab on how we can prevent cancer from spreading to the bone. And finally, the third perspective I have is that, like many of you, I have been a patient myself. I'm also a survivor. And so as a physician, that's always an interesting perspective to see things from the point of view of your patients. And that experience has taught me quite a lot. I've learned many things. Certainly as a scientist and a physician, it's interesting to see a lot of the technology, the radiology imaging, the operative procedures, all the sort of high-tech and research-based approaches to treating cancer. But one of the things that really impressed me as a patient was that I really appreciated all the warm blankets for the many, many sort of tests and encounters that you have. And I think as a broader sign of the caring that you get from healthcare providers and staff at the hospital. The other thing I've learned is that statistics look very different when you're on the patient side of the equation. I like to say that as a physician, these kinds of graphs are what we call Kaplan-Meier curves. They show you sort of the cumulative effect of whatever intervention medication you're looking at. This is an example from, I spent a lot of time reading studies about how to prevent fractures. This is one of the medications we use. And I like to say that as a physician, I'm not impressed unless the medication has a very clear benefit very early on. You can see here within 3 to 6 months, that persists and gets greater and greater. That's what it takes to impress me as a physician. But as a patient, I've learned that you can look at a graph like this, which is going out over 9 years, looking at the effects of chemotherapy or not on cancer survival. And as a physician, I would say, well, these curves look identical. But I've learned that as a patient, you can really fixate on what seems like a very small number and be concerned about that. So hopefully this has made me certainly sympathetic and empathetic towards my patients. I also know what it's like to get that call that your imaging was abnormal, that you need a biopsy, and to have to make decisions based on what your physician has told you, guided not only by statistics, but also by emotions. So this is a topic that really is very near and dear to me. All right, I'd like to start with the take-home messages. So if you remember nothing else, I hope you'll remember some of these points. Fractures due to osteoporosis are serious but preventable. There are many things that go into your risk of fracture, which we'll cover. Lifestyle changes, I'm often asked about whether they're enough to reverse the bone loss, and they can certainly help to slow things down, but often they're not enough to completely restore your bone. And finally, when used properly, which we'll talk about in more detail, osteoporosis medications are very safe and effective. All right, so let's start by talking about what is actually osteoporosis. It literally means porous bone. And it is refers to a decrease in the amount of bone you have, or your bone mass, that leads to increased fragility and a greater chance of breaking a bone or sustaining a fracture. So this is just sort of a theoretical picture of what normal bone looks like. There's a lot of these struts and plates, and I think you can see an osteoporotic bone. It's just a lot narrower. It would be easier to fracture when you lose bone mass. To put it in perspective, osteoporosis is extremely common. Half of all women over the age of 50, this is in a general population, so not only cancer patients and survivors, but half of all women over their lifetime are expected to have a fracture due to osteoporosis. You can compare that to a 1 in 8 chance over a lifetime of having breast cancer. Something we won't spend a lot of time talking about today, but men also have osteoporosis. They tend to have fractures later in life than women because they start with more bone, but the consequences can actually be more deadly for men. And so in men, about 1 in 4 to 1 in 5 will have a fracture in their lifetime, and that's pretty comparable to their lifetime risk of prostate cancer. So to give you an idea, this is a cast mountain that I saw at a meeting a couple of years ago to represent the over 5,000 fractures that happen every single day in the US. It adds up to 2 million fractures per year. And again, many of these are preventable. So we have an organization called 2 Million Too Many to talk about how many fractures we could try to prevent. Osteoporosis is a very serious public health problem that affects over 10 million Americans, 80% of whom are women. We've talked about how there are 2 million fractures per year. The costs, these numbers are outdated. By now, they're well over 20 to 25 billion per year. When we talk about osteoporosis fractures, the most common are spine or vertebral fractures, about a quarter of them. Wrist fractures are very common, particularly in parts of the country where there's a lot of snow and ice. Women can slip on the ice, fall, and fracture their wrist. Hip fractures are a category that is a little bit smaller, 14% of all fractures, but especially devastating. After having a hip fracture, many people do not recover their former independent lifestyle, so most people are not able to walk again. And so that is something that we try really, really hard to prevent. All right, so today we're going to talk about the risk of osteoporosis among patients who have had breast and ovarian cancer. These individuals are at risk for bone loss for many reasons. Chemotherapy itself can be very hard on the bones. Chemotherapy can lead to premature menopause. A woman's periods can stop. Menopause itself is a time of bone loss. For those with breast cancer that have hormone receptor positive cancer cells, endocrine therapy is a very effective way to decrease recurrence risks, but carries, unfortunately, the side effect of being tough on bones. And many patients with breast and ovarian cancer are also treated with radiation therapy, which of course is beneficial for eradicating the tumor, but when it passes through or in the proximity of the skeleton also can cause bone loss. And this is just a figure from a publication that's now a few years old, just showing that the percentage frequency of fractures of the hip, the spine, wrist, and others is higher among survivors of breast cancer than for the general population of women. I'm going to talk a little bit in more detail about endocrine therapy. So most breast cancers, actually 80%, express either the estrogen and or the progesterone receptor. Those are the female reproductive hormones. Your estrogens come from different sources. For someone who's premenopausal, the primary source of estrogen is, of course, the ovaries. After menopause, the ovaries no longer make as much estrogen, but your adrenal glands, which sit here over your kidneys, can still convert some of the circulating hormones into estrogens in your body. And because these breast cancers often have receptors for these hormones, doctors have long known that it's possible to block these hormones and therefore both slow the rate of growth for the tumor and also limit the chance of recurrence. So there are several categories of endocrine therapy depending on both the stage at which someone is diagnosed with the breast cancer, but also their menopausal status, whether they're pre or post-menopause. So we have some that block the action of the estrogen receptor in breast. Tamoxifen is the most common. There are aromatase inhibitors that prevent this conversion of androgens in the adrenal gland into estrogens. The most common are anastrozole, exemestane, and letrozole. For women who are premenopausal, but for whom their oncologists feel strongly that estrogen needs to be brought down to zero, they can be treated with what we call GnRH agonists, goserelin and leuprolide. And then finally, more recently, there have been medications that directly block the effects of estrogen, like fulvestrant. Currently, those are used for metastatic breast cancer only. These therapies for breast cancer can be very hard on the bones. Shown here in green, these are the percent of bone loss that you might lose in a given year. So in green are what happens normally with aging. So men with age lose about 0.5% of bone a year. Women after menopause lose about 1% of bone per year. That's just a natural effect of aging. The rate of bone loss is a little bit higher in the years immediately around menopause. So on average in the US, menopause occurs in the early 50s. So in the first 5 years or so, right after menopause, women can lose as much as 2% per year, but then that eventually slows down to, again, this 1% baseline. And just to give you some comparison, women who have breast cancer and who are put on aromatase inhibitors as postmenopausal women can lose more than 2% of bone per year. But the greatest risk comes in women who either were premenopausal but had to have ovarian suppression, had their hormones turned off effectively, either by removal of their ovaries or by these GnRH agonists that we talked about. They can lose 7% per year. And also women who, because of chemotherapy, went into premature menopause, their rates of bone loss are similarly quite high. So when I talk to oncologists, when I talk to patients, one of the first things that I encourage everyone to do is to screen for osteoporosis. And that means thinking about whether somebody is at risk. So there are several things that determine whether you're at risk for bone loss. They include, of course, age. Bone mass declines on average with age. If you've had a previous fracture, that makes your chances of having another fracture in the future much higher. And I want to clarify that we're talking about what we call fragility fractures. So these are fractures that happen with minimal trauma, so standing height or less. So somebody who was standing, tripped over the sidewalk curb, slipped on the ice, spontaneous fractures. We're of course not talking about fractures that happen in the setting of significant trauma like a car accident. Glucocorticoids or steroids, the most common being prednisone. Those are a very common cause among everybody, again, not just cancer patients, of bone loss. Family history is something we take into account, especially if you've had a parent who has had a hip fracture. That raises your own risk of having another fracture. Being thin this osteoporosis is one of the rare diseases for which being thin is a risk factor. We often counsel patients on the need for weight loss because overweight is associated with things like diabetes, hypertension, etc. But in the case of osteoporosis, actually being thin is a risk. Smoking and excessive alcohol also can weaken the bones. And some diseases like rheumatoid arthritis with a lot of inflammation and other hormonal and other diseases can contribute to bone loss. All right, so how do we screen patients? Our sort of gold standard test is what we call a bone density scan. This is a photograph if any of you have been to Stanford Hospital and had a bone density done there. This is our Dexa Scanner and one of our technicians at Stanford Hospital. And it's quite simple and fast. You lie on this bed, and this arm takes a quick picture through your spine and then rotates around and takes a second picture through your hips. And you end up with a report that looks a little bit like this, a picture of both your hip joint and your spine. And for the doctors who are reading the reports, they usually come with a figure like this, where the blue bars represent the average bone density for women of that ethnicity across age. So here you can see from age 20 to 100, there's sort of a very gradual decline. It declines more rapidly right around the time of menopause and then slows down again. And this is even more prominent in the spine. And then where the bone density falls on this, you can see from the colors, green would be normal bone density, all the way down to severe osteoporosis at the lowest measurements. So I want to spend a minute on the idea of fracture risk being dependent on both bone density and age. I see many patients who have had a bone density after they've had a fracture, and the bone density numbers are quote in the normal range, but because of other factors, often including age, the risk of having a fracture might actually be much higher. And so it's something to raise awareness. This is on the right side, a person's chance of having a hip fracture over the next 10 years. It's calculated both from the bone density and parameters like height, weight, gender, and other risk factors. The World Health Organization defines osteoporosis on a Dexa scan as having a T-score worse than minus 2.5. T-score is a standard deviation of your bone density compared to 30-year-old women of the same race and ethnicity. So if you have a T-score bone density that's more than 2.5 times lower than a 30-year-old, you would be classified by the World Health Organization as having osteoporosis. Now, as a collective, we have decided that 3% chance of having a hip fracture in the next 10 years is about when we recommend treatment for osteoporosis. And here I've shown the risk of fracture plotted as a function of age and bone density. So I want to point out that if you're a 65-year-old woman, shown here in this red line, at a T-score of minus 2.5, you're right at the threshold for when we would recommend medication treatment for osteoporosis. I sometimes see women who are much younger, say in their 50s, and in that case, age is protective. So if you're 55, you don't really reach that threshold until your T-score is as low as minus 3. But the converse is also true, in that a woman who is 80 is at high risk of fracture almost regardless of their bone density. So you can see here, even at a little bit worse than minus 1, which would be considered almost a normal bone density, the risk of fracture is high enough that her doctor should be thinking about treatment. The other thing that really factors into whether somebody is at risk for having a fracture is the number of risk factors they have. So this is for a woman of a given age, height, and weight, looking at different risk factors, including whether she has had a previous fracture herself, whether one of her parents had a hip fracture, whether she is smoking, being treated with steroids or glucocorticoids for any reason, whether she has rheumatoid arthritis or consumes excessive alcohol. You can see that the risk, again, of having a hip fracture over the next 10 years rises dramatically with the number of accumulated risk factors. All right, so who should have a bone density test? For any kind of screening test that we have as a population, the question is always, how do you balance the cost of screening a wide number of individuals versus the benefit of catching the disease frequently enough? So many professional organizations of doctors who take care of osteoporosis have some general agreement on who should have a bone density. Women who are 65 and older, men maybe around 70, 75 and older, Younger postmenopausal women or men over the age of 50 who have a significant number of risk factors, so things like taking steroids for some reason, having had another disease that increases your risk. Anyone who's had a low trauma fracture after age 50. So I meet a lot of women in my clinic who tell me that years ago they slipped on the ice, they broke their wrist, but nothing was really ever done. No additional testing was recommended. But somebody who's had a fracture, again, falling from standing height or lower, should really have a bone density scan. And then the last category really includes what we're talking about today. So individuals who had treatment ongoing or after for cancer is included in those who've had either a condition or medication or treatment that's associated with a high risk of bone loss. There are some cancer-specific recommendations. All postmenopausal women with cancer should probably have a bone density scan for the reasons we've talked about. The risk is a bit higher. Premenopausal women who are on ovarian suppression and an aromatase inhibitor, again, because that effectively places them into a menopause-like status, should also have a bone density scan. There's some debate among osteoporosis doctors and oncologists about whether younger premenopausal women who are just being treated with tamoxifen need a bone density scan. Tamoxifen tends to be a little bit harmful to bones in younger women, but younger women also tend to start with stronger bones to begin with. My own preference and that of many of the oncologists at Stanford is to get a bone density whenever we think of it. At least we then have a baseline, but it is something that is still a bit debatable. All right, so let's talk about bone health and what we can do to optimize it. So a while back, the Surgeon General issued a report on bone health with some very common sense and I think straightforward recommendations. So these really apply, I think, to everybody, children and adults, in thinking about ways to keep your bones as strong as healthy. And many of them you'll see are just generally good recommendations for healthy lifestyles. So getting enough calcium and vitamin D, we'll go into that in a little more detail on one of the future slides. Being physically active, so getting plenty of exercise. Decrease your risk of falls. So that is referring to specific things like, looking around your house, making sure that you don't have maybe those throw rugs that are very easily to trip on, that you have a nightlight in your bathroom so that at night, if you're getting up to use the restroom, it's not so dark that you might kick some furniture and trip. Maintaining a healthy weight, not smoking or stopping smoking if you currently smoke, limiting alcohol use. The current guidelines are less than 1 to 2 drinks per day for women and less than 2 to 3 drinks per day for men, although I've read that there is some debate about whether that should be even more stringent. And then if you're taking medications like we talked about, particularly glucocorticoids, talk to your doctor about the possibility that there is some bone side effects. All right, how much calcium should everybody have to keep their bones strong? So I try to keep things simple from the patients that I see in clinic. I tell them that they should have roughly 1,000 milligrams or 1,200 milligrams a day. Dairy products are a great source of calcium. So 1 serving of dairy product, which is a cup of milk, a cup of yogurt, or roughly an ounce of cheese, I keep in mind that those are roughly 300 milligrams of calcium. But you can see there are many other sources. Orange juice is often fortified, canned salmon with bones. People sometimes ask me, there is calcium in sort of dark green vegetables. It doesn't tend to be a lot. You'd have to eat a lot of broccoli. But you do get some additional calcium in the diet from those sources. So one option is certainly to take enough dairy products or dietary sources of calcium to reach 1,000 milligrams a day. I tell my patients that's generally about 3 servings a day of dairy products, and then counting on the fact that the rest of your diet, like the broccoli and the vegetables, will supply the rest. Most adults that I talk to, especially on a Western diet, do not typically meet 3 servings of dairy a day. It tends to be a bit unusual. So if that's the case, then we can think about calcium supplements. The important point there is that your body can't really absorb more than 500 milligrams at a time. So even though you might see in your local pharmacy or at Costco, you might see supplements that claim to provide 1,000 milligrams of calcium. Keep in mind that your body can really only absorb about half of that. So if you're going to take calcium supplements, I recommend either if you have no dairy intake at all, you could take 500 milligrams in the morning and 500 milligrams in the evening. Most people I talk to have maybe 1 to 2 servings on average of dairy products. In that case, you really just need 1 500 milligram tablet as a supplementation. I'm often asked what kind of calcium that you need. If you're taking an acid blocking medication, so something like omeprazole or one of the acid blockers, ranitidine, Zantac, then you should take a form called calcium citrate. The brand name is Citracal, and that's because you don't need acid to absorb those forms. Otherwise, calcium carbonate is the most common form. That's the one that's found in Oscal, in Tums, many of the generic sources. So about 1,000 milligrams of calcium a day. And I choose that number because it's very similar sounding to how much vitamin D I recommend, which is about 1,000 international units a day. And this is available in 2 forms. There's, you might see vitamin D2 on the bottle, and that is a plant-based supplement, usually sold in higher doses like 5,000 to 50,000. Those are more to supplement individuals who have vitamin D deficiency for various reasons. The most common over-the-counter vitamin D that I recommend is vitamin D3, cholecalciferol. That's the form that's produced in the skin by sun exposure, or found in animals. And again, somewhere in the range of 800 to 1,000 units a day of vitamin D. Some of my patients really like to take calcium supplements that contain both calcium and vitamin D. That spares them from having to have a separate supplement yet again for the D3. That's totally fine. All right, physical activity. I am very often asked by my patients whether it's possible to exercise your way out of osteoporosis. I would say that probably not, that if by the time you have high enough risk of fracture because your bone density is low, that it is unlikely that the amount of physical activity that you can do can bring that all the way back up to normal. But that being said, physical activity has many, many benefits. And I have seen some of my patients who have really improved their bone density with exercise. So the general recommendations for all adults from the American Heart Association is that we should all be having 150 minutes of moderate activity a week, or 75 minutes of vigorous activity. So moderate to me is sort of something that generates a light sweat. So brisk walking, etc. 75, the vigorous activity would be something a little more involved, like running, jogging, etc. So, roughly 30 minutes a day of moderate activity is a good baseline for everybody. On top of that, or out of that, I recommend that 2 to 3 times a week, that should be dedicated to strength training. So we know from experience, for instance, when we send astronauts up into space, they lose quite a bit of bone density. So we know that maintaining bone strength is really dependent on using them, right? So using your muscles for strength training and resistance. This can be any sort of weight or resistance training. So if you belong to a gym, you could use the weight machines, you could use free weights. If you have a personal trainer, that's a great way to ask for advice. If you're at home, some people have some maybe lighter free weights at home. I find resistant bands are a great way to get go. You can order a set from Amazon. They're not very expensive. They typically come with a booklet of examples. And working out both upper body and lower body 2 to 3 times a week is important for bone health. It's also important to maintain balance and flexibility. So exercises like yoga are really great. One of the reasons that older adults fracture more is because they fall more. And one of the contributing factors to falling more is just not having as good a sense of balance, not being able to sort of catch yourself when you start to tip over. So building in a habit lifelong of maintaining balance and flexibility is also very important. The National Osteoporosis Foundation is a great site for all sorts of information for both patients and their doctors about osteoporosis, but they do have a link to some exercises that you can check out there. All right, so those are the main lifestyle approaches to maintaining your bone strength, which is to take plenty of calcium and vitamin D, make sure you're getting enough exercise, stop smoking, limit your alcohol intake. But for many patients, particularly those who've had substantial cancer therapy or who are on endocrine therapies for cancer, they can have pretty significant bone loss. And that's when they come to me in the clinic, and we are talking about medication approaches for treating osteoporosis. So I like to teach my patients that the amount of bone you have is in constant balance in your life between cells that we call osteoclasts that break down the bone. So I think of them a bit like the mini jackhammers. And the cells in your body called osteoblasts that make new bones. So I like to think of the analogy of bricklayers. And it's this balance between the two processes that determines how much bone you have. And in general, as people age, the amount of bone that is broken down starts to outpace the amount of bone that is made. So then our approaches to treating osteoporosis are really pretty straightforward. We can either prevent bone breakdown or we can promote bone formation. Now I'm going to just go ahead and say that for patients with cancer, there's substantial uncertainty about the safety of bone formation promoting medications. These include medicines called teriparatide, abaloparatide, and romosozumab. Their brand names are Forteo, Tymlos, and Evenity. So I'm going to take them off the table. They are really not enough clinical data to suggest yet that they are safe for patients who have had cancer. So we're really going to focus today on the most commonly prescribed osteoporosis medications for cancer patients and survivors, which are the bisphosphonates and a medication called denosumab. So I've summarized really the options for medications that are safe to use in cancer patients here on a single table. And again, they really fall in two classes, what we call the bisphosphonates and then denosumab. So the bisphosphonates come in two forms. There are oral or pill forms that are given once a week, alendronate and risedronate, which you may recognize by their trade names Fosamax and Actonel. There's also a once a month version called ibandronate or Beniva. Again, these are given once a week. So, you know, these are my favorite medications to start. It's usually my first line of recommendation for somebody who's coming to see me in the clinic. They've been around for a very long time. They've been FDA approved for at least 20 plus years. They're safe and effective. The side effects of the oral versions, the most common is heartburn. And so sometimes it irritates the GI tract on the way down. They cannot be used in people who have significantly decreased kidney function or kidney disease. And then the reason that Beniva is not in bold is it has not been proven to reduce fractures of as many types as the other two have. So these have the greatest amount of data. When somebody develops heartburn on an oral bisphosphonate, then I usually recommend next an intravenous bisphosphonate called Xolodronic Acid or Reclast. It's very convenient. It's given as an infusion once a year. Again, it can't be used in patients who have severe kidney dysfunction or disease. And on the first time that I give the reaction to somebody, that I give the infusion to somebody, I do warn them that about 1 in 4 individuals can feel like they have a mild case of the flu afterwards. So later that day or the next day, they can feel like they have a mild low-grade temperature, a little bit of achiness. It passes within a day or two, and then it doesn't seem to happen again. But I think it's important to warn people so they're not caught unawares. Denosumab, which is sold under the trade name Prolia in this country, is a newer medication. It is given as an injection every 6 months. So at Stanford, you would come into the clinic and our nurses would give you the shot every 6 months. The pros are that it really nicely increases bone density, even more so than some of the other bisphosphonate medication. Probably its greatest benefit is that it can be used in those individuals who have some kidney dysfunction. So it's nice to have an option for that group. The cons are that you must be very punctual every 6 months, and it can't be stopped abruptly because that new bone that's formed will very quickly go away. And there's a little bit of caution in patients who have some immune compromise. So for instance, after a bone marrow transplant or something. But again, this is a summary of the most commonly used medications to protect bone health in cancer patients. Now, many of you may be aware of some of the publicity surrounding some of these medications, and you may be concerned about the long-term safety of these medications. I really see nothing else other than osteoporosis in my clinic, and over the years I've really heard, I think, many of the major concerns, the commonly expressed concerns. Many people tell me they prefer natural remedies, or they're very sensitive. They've read that there can be some dangerous side effects. They've had somebody that they knew who took the medication and had an unpleasant side effect. So these are very common concerns, and nothing that I've not heard before. And when somebody comes to see me in the clinic, we talk through these concerns and sort of go through the pluses and minuses of the medications. I think it's always important to keep in mind when we think about taking an action like treating osteoporosis, what are the benefits or the risks? So this is a table showing that over 100,000 patient years. So you could think of this as 10,000 women treated for 10 years or not treated. You would expect a pretty high rate of spine fractures among women who are not treated with anything, slightly less common wrist fracture and hip fracture. But if these same people are placed on bisphosphonate, you can see there's a pretty substantial decrease in the number of fractures that would be expected over this time. Compared to some of the rare side effects that people worry about with these medications, including osteonecrosis of the jaw or atypical fracture, you can see that they're really exceedingly low, far outweighed by the benefit, which is the number of fractures that are prevented. And more importantly, that especially for atypical fracture, we really don't see even a discernible uptick in the number until somebody's been on the medication for 10 years. So you may have heard your own doctors or heard in the news that we now recommend treating for 5 years, followed by a holiday. And that's really because we now know that after 5 years, if we pause for just a year or two, we can set that risk almost back to baseline. Another way to think about it is that, again, if you were looking at now 10,000 patient years, these are the numbers of fractures that would be prevented by treating this group with medication. And over that same amount of time, you would expect to see about 3 cases of osteonecrosis of the jaw, maybe 2 cases of atypical fractures if you treat for 5 years, and a few more if you were to treat for 10. So what this really tells us is that, again, if we take a holiday after 5 years, that in appropriate patients, the benefits of treating for 5 years far outweighs the risk with these medications. All right, so in the last few minutes about the bone health portion of this talk, I want to turn to the idea of how we can manage bone involvement by cancer or bone metastases. So you may know that cancers can spread beyond their original site of origin. So for breast, that means going to distant organs like brain, lung, bone. And for reasons that we still maybe don't entirely understand, bone is always one of the most common sites. So estimates are that 2/3 to 3/4 of patients who have metastatic or stage 4 cancer have involvement of the bone. So in those patients, we very much want to prevent certain complications, things like fractures, because the cancer is locally breaking down the bone, the need for radiation to bone or surgery, depending particularly if it's in the spine, you can get complications like spinal cord compression from these bone lesions, and then there can be high calcium levels that result from the breakdown. So we know that Xolodronic Acid, that's the medication that we've already seen under the name of Reclast, can substantially decrease the frequency of complications that result from metastases. This was a study early on from a little over 200 women who had breast cancer and bone involvement. They were treated with Reclast monthly for a year, and you can see their rates of complications here in the summary is significantly less, about 40% lower than those who are treated with placebo. So these osteoporosis medications at higher doses are also very effective at limiting the bone complications from widespread disease. Denosumab has also had very good data to support that it's beneficial for the same reason. This is a small study actually showing that denosumab may be even a little bit better than Reclast. Other studies have shown that they are pretty equal. But again, both options are very good for treating bone metastases. The issue that I want to bring to your attention is that the doses used for osteoporosis and what I call oncologic dosing for metastatic disease, though, are very different. So for osteoporosis, we talked about intravenous Reclast. That's a 5 milligram once a year dose. And we also talked about Prolia, which is a 60 milligram dose every 6 months. When we talk about doses that the oncologists use for metastatic disease, however, they give the same chemical compound under the name Zometa, 4 milligrams every month. That's a 10-fold difference over 1 year. And similarly for denosumab, it's given by oncologists as Xgeva, which is 120 milligrams every month. So over the course of a year, that's 12-fold higher. The reason that it matters is because when these studies were first done, many of the trials for metastatic cancer were done over 24 to 36 months. At the time, 15 to 20 years ago, the survival for many patients with metastatic cancer was really in that duration. But the survival is improving because of all of the advances in both chemotherapy agents, but other endocrine therapies. And my colleagues at Stanford, Alison Kurian and Jennifer Caswell-Jin, have recently published a study showing that, in fact, since 1990, the median survival has improved 50% from 20 to 31. And in fact, I have several patients, many patients who have survived even far beyond that. So that, of course, is good news. But the challenge is then that we're still uncertain about how long and what kind of dosing these individuals should get for these medications. And the reason is because that some of the adverse events are, in fact, much more common when we use such high doses. And finally, for anyone who is taking Prolia or Xgeva, something that is important to let your oncologists or your primary care doctors know about, which is that these medications can't be stopped abruptly. You can see here, this is bone density in the spine. These are women who are in the group that received denosumab. You can see over 2 years or 24 months, bone density really rises very nicely compared to placebo, where women are losing bone density with age. But if the denosumab is stopped here at 24 months, you can see that very quickly goes away, all the way down to baseline within a year. And if you look in the hip, again, a nice increase while being treated, but when it's stopped, it can actually decrease below. And this has now been reported to be associated with a larger number of spine fractures in those who were sort of abruptly stopped from denosum, again, either Prolia or Xtupa. So really now what we recommend is that somebody who has been treated with those medications, if something arises, maybe you've been treated enough, maybe the bone density is high enough, maybe you want to have a holiday, rather than just stopping and doing nothing, they should be switched to either alendronate, which is Fosamax, or Xolodronic Acid, which is reclassed. All right, so again, to revisit the take-home messages that we have here, fractures that are due to osteoporosis are quite serious and common, but they can be preventable. Your own risk of fracture will depend on a number of factors, including age, whether you've had previous fractures, whether you've had medications that are tough or toxic to the bones. For most women who have serious osteoporosis and a high risk of fracture, lifestyle changes can slow but not completely reverse that bone loss. But I want to reassure you that the medications that we use for osteoporosis, when used properly, can be safe and effective. Finally, just for the last 2 minutes or so, I want to share a little bit of what we've also been working on in the lab, because of course, as many advances as have been made, we can always do better. So one of my interests, of course, is cure for osteoporosis, and we have been working very hard on trying to convert stem cells into bone in the lab, hoping that that might one day be a therapy for osteoporosis. And this is just to show you that we have figured out how we can take cells in the dish and convert them into bone-forming cells that we call osteoblasts. And here, the red stain up here and the black stain down here are just ways for us to prove that these cells really do function like bone-forming cells in a dish. And that if we look under a microscope, we can show that they really have the identity of bone-forming osteoblasts. We have been able then to take these cells and implant them into mice, and we can show that if we implant the cells, they can form bone after a couple of months, that you can see here on a CT scan, compared to cells that were not converted into bone-forming cells. They really make a minimal amount of bone, and that you can see under a microscope. Again, when you implant the osteoblast cells, they make bone, shown here in the red stain and the black stain, that really doesn't form when you implant the non-converted cells. So we're very optimistic that will give us a new way, a new approach to increasing bone formation by using stem cells as a starting point. The other area that my laboratory has been really focused on, I mentioned early on in talking about the ways that we can treat breast cancer, that we don't really consider using the bone forming medications right now, because there are concerns about their safety. And so we decided to look at this starting with some animal models. The reason is because, of course, as I've just spent the last hour telling you, that osteoporosis and its milder form osteopenia are very common in patients who've had breast cancer, both because of menopause brought on by chemotherapy, some of the endocrine therapies like aromatase inhibitors. There are some limitations to these medications. We've talked a bit about the risk of osteonecrosis of the jaw and atypical fractures, particularly at high doses. We've talked about how they cannot be used in individuals who have kidney dysfunction. And finally, ultimately, they can never cure osteoporosis because they don't increase bone formation. They just prevent the breakdown. And so for many reasons, it would be nice to know if we could use these bone-forming or anabolic treatments for breast cancer patients. So we have been studying mice who are modeled to have breast cancer, and we treat them with either PTH, which is the bone-building medication, or just salt water. And I think you can see these are miniature CAT scans of their bones. And I think you can see that in the control mice that just got salt water, there's a lot of destruction of the bone from the cancer involvement, but that we can really prevent that for most of the mice when we treat with PTH. And even more exciting, we found that when we use PTH to treat with these mice that have breast cancer, we can in fact improve their survival. So good news if you are a mouse with breast cancer, but I think this gives us some justification for looking into doing some studies in people, of course, trying to benefit individuals. All right, with that, I want to thank, these are the members of my laboratory. This work is expensive to carry out, so it requires a lot of support from various funding sources, including the federal government, the National Institutes of Health, the Department of Defense, and the Mary Kay Foundation has been instrumental in supporting this kind of work. And with that, I really thank you for your attention, and I hope now we have plenty of time for questions.
Thank you so much, Dr. Wu, and thank you for everyone that was able to join us today. We definitely do have a lot of questions, so let's get started.
I think I'll stop sharing my screen, then I can see. Great.
Perfect. Okay. So the first question I have for you is, can anyone come to your clinic for a consultation, or do you need a referral?
It takes a referral to get into the clinic, and I will be honest that my clinic waiting list is several months long. So part of the goal of sort of sharing this information is that you'll have be empowered to discuss it with your primary physicians or your oncologists, because I think it's important to get that information out.
Perfect, thank you. The second question I have is, what food or drink should you avoid while trying to build strong bones?
So I don't really like to limit any one particular kind of food. I think a healthy diet, low in salt, and generally healthy, food intake guidelines are more helpful. I think that ensuring that you have adequate calcium and vitamin D are important. But there is nothing that we can't have really in moderation. But no one thing that I would absolutely prohibit.
Thank you. The next question is, are there any exercises that should be avoided?
Right, so good question. I often have patients ask me, particularly when they have a new diagnosis of osteoporosis, whether they should avoid certain kinds of exercise. I certainly, as you've heard me say, I don't think that we should avoid exercise in general, because it can be very beneficial to bones. But I think there should possibly be caution in things that maybe are fracture prone. So to give you an example, I often tell patients that if you have a new diagnosis of osteoporosis and you have never done these activities, I would not at this moment recommend taking up something like skiing or horseback riding or any other kind of high risk activity. But certainly walking, jogging, regular sports activity, even working in the gym with careful supervision, none of those are really hands off. You just want to be careful about form.
Thank you. The next question is from a client. I'm reluctant to take calcium supplements due to kidney stones, eye, and heart issues, sometimes associated with calcium supplements with taking an L. What is your recommendation? What are the most important things to do for your bone health if we don't take a calcium supplement?
Right, good. So that is reasonable. Certainly calcium, kidney stones, the most common forms involve calcium. So you certainly don't want to overdo it. Ironically, avoiding calcium completely also raises your risk of kidney stones. It's sort of less able to be absorbed and it passes through the urine. So even for patients who have kidney stones, I recommend, maybe in the range of 800 milligrams of calcium. If you really don't want to take supplements, you alluded to a little bit some of the work that has been reported about possible risks to the heart. Those studies were really still very controversial. When they weren't designed to answer that question, it was reported as sort of a tangential finding from other kinds of reports that calcium supplements can damage the heart. And when you look at the data, that seems to be in supplements that are taken at very high doses. So again, I recommended 1,000 milligrams, and these side effects seem to happen at 3,000 to 4,000, which I would never recommend, because that does certainly increase your risk of calcium kidney stones. But if someone is concerned, you can do it entirely through diet. So again, 3 to 4 servings of dairy products a day, or fortified orange juice, or other calcium-rich foods can get you the same degree of calcium without the need to take supplements.
Okay, perfect. This is a good next question as a follow-up then. Any suggestions for other calcium food sources if we are not consuming dairy?
Right, so some foods are fortified, like orange juice. Tofu can be quite a good source. You can find by Googling lists of foods and their calcium contents. The NIH, I know, maintains a website. The National Osteoporosis Foundation that I referred to in my talk also has a list of foods and their calcium content. So you can sort of look at those and see what other options might work for you.
Thank you. The next question is, are there any concerns around dairy and breast cancer reoccurrence risk? Is that just a myth?
Dairy and breast cancer myth. Recurrence. So I'm not really familiar with data that says that dairy products are associated with breast cancer, but again, I'm not an oncologist, so it is not my primary field. I think there are many things that have been sort of reported to be associated with breast cancer, and you always have to be cautious because those recommendations can seem to go back and forth, but I do not have any reservations about recommending dairy products.
Thank you. The next question is, are there any negative side effects to having a bone density scan like radiation?
Great question. So it involves some radiation, but it's really minuscule amounts, far less than it might be involved in a chest x-ray or a CT scan. And really it's what we call a non-invasive test. You lie on that table that I showed you that picture of, and that arm rotates around the table to take essentially radiographic pictures of your spine and hip, but without ever touching you or your skin. So there's very little pain or damage, and the radiation dose is very, very minute.
Thank you. The next question is, how do I know what my Bmdt score is?
So it's reported on the bone density scan. So if you were to have a bone density scan, you can ask your doctor to release that report to you. And it is always listed, usually in a table form, next to a picture of the spine.
Thank you. The next question is, how do you define an osteoporosis fracture? Is there any fracture after being diagnosed with osteopenia and osteoporosis considered an osteoporosis fracture?
Great question. So an osteoporotic fracture is what I call a fragility fracture. So a fracture that either happens spontaneously, which can happen quite commonly in the spine. Strangely, half of all spine fractures are asymptomatic. So you may be familiar with older adults in your life who have lost significant amounts of height or maybe have become very bent over. That often is the result of a spine fracture, which is asymptomatic. But otherwise, people can have fractures that occurred with what we call minimal trauma, meaning you were standing up, you tripped against the curb, you fell down on the ground, fractured either a wrist or a hip or sometimes the arm. And those are all fragility fractures. And a fragility fracture alone is really enough to diagnose osteoporosis. So I often see people who have had a fracture in maybe the last few years who were then appropriately sent off to have a bone density scan, but the bone density scan came back either with mild osteopenia or even normal bone density. And then the ordering physician stopped because they thought everything was okay. But the take-home message is that a fracture always trumps bone density. So once you've had a fragility fracture that really is osteoporosis, a bone density scan is not perfect. It doesn't capture all of the risk of fracture. So if somebody has had a fracture, then the bone density scan numbers themselves are less important.
Thank you. The next question is, what's the best way to combat aromatase inhibitors' effect on periodontal health?
Well, I'm not a dentist, but or a periodontist. I think that would be a conversation with your dental and periodontal providers. Certainly, good oral health practices, brushing, flossing, healthy diet, that kind of thing, will be important. But that's the extent of my knowledge in that arena.
Thank you. The next question is, does Faslodex, when combined with something else like Ibrance had progression, mean that cannot use Faslodex alone or with other chemo or treatment?
I think that's an oncology question. I'm not really familiar with what Faslodex, let me just Google really quickly. Okay, that's fulvestrant, and I don't know what Ibrance is. Okay, that looks like a chemotherapy agent. Right, so those are medications that certainly the Faslodex currently is used in the US for metastatic disease only, is my understanding. But yeah, that is really a question for an oncologist. It's not something that I have a great deal of familiarity with.
Thank you. The next question is, what are the costs of the 3 types of bisphosphonates? Are they typically covered by insurance?
Great question. So the oral pills are very inexpensive, particularly alendronate and risedronate are now generic. So they are very, very inexpensive and typically covered by insurance as a first line. The intravenous bisphosphonate is probably on the order of about $2,000 for an infusion. It is almost always covered by insurance when it's prescribed because someone was not able to tolerate an oral bisphosphonate. Occasionally, a patient will prefer to skip over the oral and go straight to the intravenous, and then sometimes we have to appeal to the insurance company to cover it. But if it is being prescribed for the reason that someone couldn't tolerate oral, I've never seen it not covered. Denosumab is, again, it depends, but probably in the range of a few $1,000s per injection. But again, I've typically seen it covered by insurance. It's not something we've had a problem with.
Thank you. The next question is, I take calcium by the name of bone renewal from Synergy. It is a plant-based and from Icelandic red algae. Is it a good alternative?
So I think the important thing is to look at the label and to see how much elemental calcium there is. So sort of keeping within the guidelines that you want to have, if you're going to do all supplements, no more than 500 milligrams at a time, twice a day to total up to 1,000 milligrams.
Thank you. The next question is, what's your opinion on taking Prolia with hormonal replacement therapy for treating osteoporosis? This is for someone that has triple negative breast cancer, has their ovaries removed, and has a T-score of 3.1.
Okay, so Prolia with hormone replacement. So I think you're referring to hormone replacement and not endocrine blockade. So hormone replacement, is an area that's gotten a lot of attention. If you go back probably 15, 20 years, it's been well known for a long time, of course, that men have more heart disease than women, and that the rate of heart disease goes up in women after menopause. And the very natural assumption was because women lose their estrogen levels after menopause. And this led to many decades of giving women hormone replacement therapy as a way to prevent heart disease and limit some of the complications of bone loss. The Women's Health Initiative study in the early 2000s was somewhat shocking at the time. It came out with the conclusion that, in fact, hormone replacement therapy does not really improve the risk of heart disease among women, that it clearly raises the risk of breast cancer, and that its beneficial effects on the bones can now be accomplished by using things like Fosamax and other medications. So for that reason, I do not use hormone replacement therapy as part of my treatment options for bone health. And I think in the setting of a history of cancer, I think that would be something you would want to do very cautiously. There is really not any reason. Prolia is already a very effective medication for increasing bone density. So there's not a lot of reason to think there would be any benefit from adding hormone replacement therapy on top of Prolia. And there's quite a bit of concern about risk of cancer, also risk of blood clots and heart disease.
Thank you. The next question is back to bone density. What is a bone density test, which I believe you covered, but the other part is what CT scans am I told my bone mets are stable, so we do not have to take any other bone density test? Is it necessary?
So bone density scan and CT scans, they do different things. CT scans are used by the oncologist to either look for the presence of cancer and spread to other organs, or if you have a known are undergoing treatment for known cancer, to monitor the effects of that treatment. So somebody who has a CT scan to monitor their bone metastases and that being stable, that's great, but that doesn't, I mean, the radiologist will sometimes report that the bones look like osteopenia, but a bone density scan is still a gold standard method for testing the bone density. So they're really for different purposes.
Thank you. And Colleen, just a quick check-in on time. Do you want to cut it, or do you want to keep taking questions? I don't want to keep Dr. Wu either too long. I know we still have a couple questions to go over.
Yeah, and we still, I think we have Dr. Wu until 2:30, so we still have some more time.
Happy to keep going.
Okay, perfect. Just wanted to check in with everyone. Okay, the next question is, are there some types of chemotherapy agents worse than others for bones?
That's a good question. Again, I'm not an oncologist, so I don't have a great deal of knowledge about that. I think that certainly chemotherapy agents often are tough on many organs, and they certainly can be tough on bone, but I couldn't give you specifics about which ones.
Thank you. The next question is, what about Zometa quarterly infusions?
Yeah, great question. So there has been a movement. I think the oncologists are realizing that the doses that they use for these medications, which at the time that the studies were designed, these very frequent doses were somewhat arbitrarily chosen. And the good news was that they worked. I showed you some data that they decrease things like fractures and the need for radiation from bone metastases, but I also showed you the downsides, which is that at these doses, they can be much more likely to be associated with risk factors. So the oncologists are starting to realize that maybe we don't want to give such high doses for so long. And so there was, in 2017, several studies published that show quarterly Zometa is as effective as monthly. And so that's been, I think, more and more oncologists are starting to use quarterly Zometa. I have been talking certainly at Stanford to the oncologists that I work with to suggest that in patients who have sort of stable disease, who've been treated for a few years on either monthly or quarterly Zometa, that maybe we could think about even decreasing that frequency even further. But I want to be clear, there are no data yet on that. It's an area that we desperately need some more study to figure out the best path.
Thank you. The next question is, I have been on anastrozole for 16 months. My oncologist said a side effect is osteoporosis. I had a bone density done at the beginning of treatment. She did not mention to prevent osteoporosis, but recommended calcium supplements. Should I ask her about preventive medication or wait to see what she should suggest later on?
Could you either repeat or spell the drug name?
Of course. Anastrozole.
anastrozole.
Perfect. So that's one of the aromatase inhibitors. It is associated with significant bone loss because it essentially brings a woman's estrogen levels close to zero. Of course, that's what you want to prevent the breast cancer from coming back, but we know that can be hard on the bones. So it's great that you had a bone density scan. I think I can't really comment without knowing more about what the numbers actually were or any kind of fracture risk, but these are the kinds of people that I evaluate in the clinic, and it's really about where the fracture risk is as a whole, whether to recommend treatment.
Thank you. And the next question is, has the incidence of osteoporosis increased over time? Are people living in specific countries or communities at increased risk or developing osteoporosis?
Oh, that's a great question. That's probably for the epidemiologists who've been studying over time. I can tell you that it is already very common, more than 50% of women. The number of hip fractures, which I think I alluded to, is probably the fracture that I'm most vested in preventing because they are so devastating when they happen. The number of hip fractures had been slowly declining in this country and in many other developed countries over time with the introduction of osteoporosis medications. Unfortunately, after the media portrayals of osteoporosis medications being risky, that led to many patients and their physicians stopping these medications, and sadly now the numbers of hip fractures are climbing. But beyond that, I couldn't give you more details about how it breaks down over the globe.
Thank you. The next question is, what are some of the most important factors that can drive cancer metastases to bones?
Yeah, so that's certainly something we're very interested in the lab. It started from our interest that you may know that your blood cells are made in your bone marrow, and your bone marrow is typically sort of located in the middle of your bones. So you may even have sort of seen marrow served in restaurants, or et cetera, but the hollow space inside of bones is where blood cells are made. And it's become apparent in the last 10 to 15 years that your bone cells play an important role in your ability to make blood cells. And so that's how we started in this area. The theories about why cancer cells like to go to the bone so much is that many of the same molecules that bone cells use to support blood cells are in a way hijacked by the cancer cells. And so that the cancer cells recognize some of the molecules that bone cells are expressing, and that allows the cancer cells to sort of home into the bone and spread there. And so that's a thought about why bone is one of the most common sites for cancer to spread. And so we're very much interested in looking at approaches to make bone basically less attractive, less able to support cancer cells, so that we can try to prevent these metastases.
Thank you. The next question is, what risk factors contribute to individuals developing some of the feared side effects of taking osteoporosis medications?
So the risk factors for osteonecrosis of the jaw, that's a condition where the jaw, there can be sort of bony problems in the jaw that are usually in response to trauma. So the risk factors are cumulative dose. So either taking the medication for, as I showed, more than 10 years, taking very high doses like are prescribed sometimes for cancer patients, things that are traumatic to the jaw. So, very invasive dental procedures, poor oral health, those are all things that can contribute to that risk. The risks for the atypical fractures are not as well understood. There does seem to be a slightly higher prevalence among Asian females, whether that's because on average the body size is more petite for Asian women compared to other ethnicities, and therefore it's just about geometry is something that is still being investigated.
Thank you. Let me just find my place in the questions real quick. The next question is, how often should a woman that is postmenopausal or premenopausal and estrogen blocking therapy have a DXA scan?
Good. So bone changes rather slowly over time. It's not a fast changing organ. And on average, insurance companies will cover a bone density or a Dexa scan every 2 years. And so that's reasonable. I think it is a very small amount of radiation, but you don't want to do any more than necessary. But I think, every 2 years, unless there is a reason to suspect very, very rapid ongoing bone loss, is reasonable.
Okay, and just a quick follow-up. I don't know if you already answered this with that, but I got a DEXA scan last year just before starting chemotherapy. It showed I had osteopenia. I'm now on Tamoxifen.
Mm-hmm.
What should be a good time to get another DEXA scan? Thank you.
Good. So again, that is really dependent on a number of factors, including somebody's age, what the actual measured bone density was, whether they've had fracture, whether they're at high risk for fractures, etc. Tamoxifen in postmenopausal women tends to be protective for bone, so it's a great option. In premenopausal women, it tends to be a little bit negative on bone, but again, premenopausal women often have more bone to start with. Probably not more frequently than every 2 years, but if somebody really was at low risk, it could be even longer than that.
Thank you. The next question is, can you take too many milligrams of calcium in one day?
Yes, absolutely. If you take too much calcium, you certainly will raise your risk of kidney stones because that extra calcium will pass out through the urine in the kidney. And there has been some publications that I mentioned that are a little bit controversial that very high doses of calcium supplement may lead to some heart damage.
Thank you. The next question is there a correlation between Lupron and bone density?
I'm sorry, correlation between what?
Lupron, Lupron?
Okay, absolutely. Lupron is one of the GnRH agonists. It's used for ovarian suppression, for instance, in either women who are premenopausal who need to have complete blockade of their estrogen, also used in men with prostate cancer for a similar reason. And so whenever you completely block your reproductive hormones, it can lead to substantial bone loss.
Did we get through all of them? You ready?
Did we lose it?
We may have lost her, but I think that was about the end of our questions. So thank you so much for joining us today, Dr. Wu. It's been a pleasure to have you and to learn from you, and we appreciate your time and hope to have you back again soon.
My pleasure. Thank you so much for having me, and thank you all for listening. I hope it's been helpful.